Subtopics which will also include in today's presentation are technique and normal anatomy of gallbladder. However, special emphasis should be given when patient presents with complaint of pain in right hypochondrium, upper abdomen, or there is mass in right hypochondrium, or patient has jaundice. Patient should come for ultrasound with proper preparation, that is at least 6 hours fasting. Why? Because as a result of fasting, gallbladder becomes distended and also there is reduction in bowel gas shadows in upper abdomen. We start scanning in supine position. We use a probe that is 3 to 5 megahertz curvilinear probe, better with our Doppler facility. To perform ultrasound of gallbladder, we use either subcostal view and also intercostal view. In subcostal view, a deep inspiration will improve in the visualization of gallbladder. Intercostal view is a superior and lateral view through intercostal space, and in this view we use liver as a window. Different positions are used during study of gallbladder. These include supine, left lateral decubitus, left posterior oblique view, sometimes prone or upright view as well. Here we can see that a patient is being examined through a subcostal view with a probe which is placed longitudinally. And he is also in left lateral decubitus position. So we will see a gallbladder. Normally, gallbladder appears as an anechoic structure. It is pear-shaped. It shows a fundus, a neck, and a body. The size of gallbladder depends upon the fasting stage of patient. If he is adequately fasting, it will become distended with bile, and it will measure maximum 7 to 10 centimeter in length and 3 to 4 centimeter in diameter. Regarding gallbladder wall thickening, it is appropriate to take thickening anteriorly in a cross-sectional view. That is, a probe is placed transversely. From here we will take gallbladder wall thickening, and it should be less than 3 mm. Another slide of anatomy. This is left lateral decubitus view, and we can see cystic duct parallel to CVD and joining it. So this view must be obtained to examine not only the cystic duct of gallbladder but also CVD. Sometimes patient is not fasting properly, and what we see is a contracted gallbladder. The most common cause of contracted gallbladder is recent meals. Why? Because it will result in release of cholecystititis, which will result in contraction of gallbladder. So इसकी close differential है chronic cholecystitis से. So sometimes it becomes difficult to differentiate between two conditions, and we call the patient once again with proper fasting. In contracted gallbladder, lumen is less than 1 centimeter and wall appear thickened. This is pseudo thickening. Gallbladder wall shows striated appearance and pseudo thickening. So we should call patient once again with proper fasting. Now common pathologies. Most common pathology is gallstone. Gallstones appear as echogenic foci within the gallbladder lumen, and they cause posterior shadowing. This shadowing is due to the fact that gallbladder calculi contains calcium, and they obstruct the passage of sound beam through them and posteriorly. So there is posterior shadowing. Here a calculus is seen, echogenic focus within the lumen with shadowing a larger calculus, and in this case multiple calculi are seen causing shadowing. During the examination we found that these are mobile in nature, they are moving within the gallbladder. Faceted gallstone appear like turtle back. They are echogenic foci with angular margins and show again posterior shadowing. These are multiple faceted gallstones. Sometimes a bile is unusually dense, so calculi will appear floating within the bile. These are the floating calculi, again echogenic foci with posterior shadowing. Sometimes we do not see gallbladder in gallbladder fossa, rather we see multiple echoes within the gallbladder fossa with posterior shadowing. This is known as wall echo complex. We see arcs of shadow and which are echogenic with posterior shadowing. The wall echo complex is a reliable sign of a gallbladder that is filled with calculi. This echogenic line is due to gallbladder wall itself. The other line, which is dark, is due to some bile in the gallbladder, and finally this line is due to gallstone within the gallbladder. So we see wall echo complex. Sludge within the gallbladder may appear as low or high level internal echoes, partially or completely filling its lumen. There is no shadowing due to sludge. Sometimes echogenic foci are seen within the sludge which cause shadowing posteriorly, and these are stones. So sometimes we may see sludge and stone together. Sometimes sludge is seen in form of balls. Here we can see small balls, maybe sometimes larger, but it is floating within the lumen. It is mobile during the study, but it is different from the stone because it is not causing any posterior acoustic shadowing. So sludge balls within the lumen should be appreciated. Another pathology is polyp. Polyp also appear as echogenic focus. When I see echogenic, it means it's bright. It is adherent to wall. During the study, it is non-mobile. It keeps adherent to wall and there is no posterior shadowing. A single polyp or multiple polyps along the wall may be seen, but you can see they are not moving away from the wall. They are not moving into the dependent portion. So these are adherent to wall. So it means within the gallbladder lumen, we may see gallstone, sludge ball and polyps. Gallstone are most common pathology. They appear as echogenic foci with posterior shadowing and they are mobile during the study. Sludge balls also appear as echogenic foci, but there is no posterior shadowing. They are also mobile. And when we see an echogenic focus, that is non-mobile, that means that is adherent to the wall and there is no shadowing, that is a polyp. To see the mobility of in these echoes, we ask the patient to take different positions during the study. So we can see that are they mobile within the lumen due to change in the position or they remain adherent to wall. Ultrasound in acute cholecystitis, common ultrasound findings which are seen include distension of gallbladder, presence of calculus, diffuse wall thickening, pericholecystic fluid, presence of sludge, and an important finding is sonographic Murphy signs. It means when we place probe in right hypochondrium for examination, patient feels tenderness. This is known as sonographic Murphy sign. This scan shows diffuse gallbladder wall thickening. It is when it is more than 3 mm, it is abnormal. Here a stone is also seen. Another patient, diffuse gallbladder wall thickening, presence of sludge and stone. Another patient with stone, sludge and diffuse wall thickening. In this patient, besides diffuse wall thickening, sludge and stone, we also see small amount of pericystic fluid, pericholecystic fluid around the fundus of gallbladder. This patient shows distension of gallbladder, calculi, and when we trace, there is a stone in the cystic duct. This is the neck region and here is the cystic duct region. So this cystic duct stone is impacted and patient has acute cholecystitis. What is a mucocele? Mucocele is basically due to chronic obstruction of gallbladder at the level of cystic duct, which results in distension of its lumen with mucin, which is basically a sterile, non-pigmented fluid. Here we can see there is a echogenic focus, basically a calculus with shadowing in cystic duct, which has resulted in distension of gallbladder. In longitudinal view, this gallbladder will measure more than 10 centimeter in length. In transverse view, it will measure more than 4 centimeter in diameter. So this is a mucocele. Here an additional finding is gallbladder wall thickening. With a mass in the right hypochondrium, and they have pain, but there are no signs of infection. On the other hand, empyema is a condition which is basically complication of acute cholecystitis. Patient present with pain in right hypochondrium, fever, rigors and chills. Here we can see that the gallbladder is distended and it contains now a fluid which is not clear. It is debridous fluid, appearing with like a sludge. So basically this is pus. Gallbladder is distended with pus, and here we can see calculi. Gallbladder wall is also thickened. So distension of gallbladder as a complication of acute cholecystitis, and gallbladder is distended with pus. It is called empyema. It is a surgical emergency. Chronic cholecystitis, as all of you know, that is due to complication of recurrent acute cholecystitis. In 95% cases, it is due to stone. Here we can see a stone within the gallbladder. Gallbladder is contracted with diffuse wall thickening. This patient has history of recurrent acute cholecystitis and also biliary colic. In this sonogram, we can see diffuse gallbladder wall thickening. There are a number of causes of diffuse gallbladder wall thickening, but common findings include acute and chronic cholecystitis, acute hepatitis, hepatic cirrhosis, CCF, acute pancreatitis, and infections like enteric fever and dengue fever. This is a case of dengue fever. It's a common finding to see gallbladder wall thickening, and also we can see free fluid around the spleen. Gallbladder mass basically appears as solid or hypoechoic, means with low aqueous mass, which is replacing almost whole of the gallbladder, and it is engulfing gallstone within it. So it is a gallbladder mass. Sometimes gallbladder mass appear as a polypoidal mass, solid mass. Here we can see a mass projecting from the fundus into the lumen. So this is the most common presentation of gallbladder mass, and sometimes it may also present like adenomyomatosis. In this condition, gallbladder shows diffuse wall thickening, but it also shows echogenic foci, and these foci cause an artifact which is known as comet tail artifact on grayscale imaging and twinkling artifact on Doppler imaging. So this is a case of adenomyomatosis. Thank you. Any questions?